right, good morning. So I'd like to introduce both speakers. We're having co-speakers today, and this is Don Teed. He is a hospitalist at West Suburban Hospital, and that's actually where Mel and I were practicing for 20 years. And he was our great resident. And then we have Patrick Smith. He also was at West Suburban, I think, just for one year, and you were Don's intern. Wow. And then now Patrick is at UCSF at the VA. They're both hospitalist and nocturnist. That must be for children to take care of kids, right? In the daytime, maybe, I don't know. But and so they work together and reconnected. And for the past 1 year, they've been working on a real systematic review for AI in critical care. And we're very proud of their work and looking forward to hearing your presentation. And many people claim they're doing a systematic review, but they don't really understand what it is. These guys know and worked really hard. So welcome. I think you're speaking first.
Thank you. So to be clear, this is not a systematic review. This is just going to be a bit of some this presentation, no. We would not be able to cover a systematic review in 60 minutes. This is just kind of updates on what we think are important studies from the past kind of 12 months in critical care, and interesting directions for study moving forward. So it's just a roadmap. First, because we think it's important to know what is available clinically right now, just going to give a brief overview of current FDA-approved AI-assisted devices, and then go over 10 interesting studies from AI and critical care in the past year, covering things like clinical deterioration, sepsis prediction, glucose control in the ICU, mortality in mechanically ventilated patients, extubation readiness, and then ICU readmission risk, among a few others. So it's as of 2 hours ago, there are 1,247 different FDA-approved AI-assisted medical devices. Now, as you can see from the chart, 3/4 of them are in radiology, and so every patient at some point is going to have imaging studies that could potentially be assisted by AI technology that is already FDA approved. But in addition, what may be less broadly known is the number of AI devices or FDA-approved AI devices in other fields, such as the cardiovascular system, neurology, anesthesiology, for ones that are a little bit more applicable to the critical care setting. And so just know that there are a lot of resources already available, and they're coming fast and furious, and it's a burgeoning field and going to be hard to keep up moving forward. So first study, the authors also actually I think mentioned in Dr. Osborne's talk yesterday. He was talking about a study in which he and his collaborators were looking at what was the earliest indicator that someone was going to develop symptomatic COVID-19 infection. And he expected it to be a rise in temperature, but what they found was heart rate variability was kind of the earliest predictor. And that was the kind of hypothesis that these authors or study designers also had. So they wanted to use continuous ECG without any other clinical data in order to try and predict when someone might have a rapid response call and then have a change in level of care. And so they figured that in continuous ECG, we'd be able to see things like the morphology, but also heart rate variability with the autonomic nervous system regulating when someone's in an inflammatory state or starting to have some cardiovascular changes. And so they designed this AHI-PI in order to compare it head-to-head with vital sign abnormalities for what was the best at predicting someone who would have a rapid response and then need to be upgraded to the ICU. So it was at University of Michigan, all patients with a rapid response over this time period, about 8 or 9 months. And again, they were looking at their AI model was looking at the continuous ECG for heart rate variability and ECG morphology. And so they did exclude patients where they felt like the ECG wouldn't reflect necessarily their autonomic nervous system state. So patients with heart transplants, ventricular assist devices, and chronic arrhythmias. Also anyone who they didn't have their AHI-PI data on, and then compared the two. So for comparing to vital signs, that was hypotension plus tachycardia or tachypnea. And, of course they did all their analysis, but I want to draw your attention to, in the bottom left here, this is saying that for all the 96 rapid response events that required a change in level of care, only 42 of them were led with a change in the vital signs based on their definition. And so that was only 43% of the patients would vital signs have prognosticated that someone was going to be upgraded in terms of level of care within 48 hours, whereas their AHI-PI model had 93%. And so this ended up leading to their FDA approval and demonstrates that we can use machine learning models to anticipate someone deteriorating on the floor, and also with a surprising limited amount of information, right? Like they didn't have access to anything else in the chart, just the continuous ECG data. And it's not meant to replace mechanisms. There's sensitivity and specificity considerations to keep in mind, but it is, they were catching twice as many patients who were going to end up deteriorating on the floors.
Then the next study that we were looking at is a study that was published in November of 2024, and what the authors were asking or trying to figure out was, can machine learning predict the development of sepsis? As you know, sepsis is a widely prominent problem in the hospital. A third of patients, are admitted to the hospital, or I guess I won't quote the exact stat, but predicting this obviously can lead to a great reduction in mortality. And so this team just wanted to really see if the initial presentation of the patient could, and the parameters that they were deriving could actually predict whether or not these patients that might be more of an equivocal presentation, not just a slam dunk sepsis, could be predicted with machine learning. So what they did in the development of their algorithm, they named the sepsis immunoscore. They had 22 input parameters to generate this risk score, and that was just basic things, vital signs, ECGs, chest x-rays, etc. Then their primary endpoint that they were looking at was the presence of sepsis as defined by sepsis 3 within 24 hours of a test initiation. They used 5 different institutions from over 5 years, from 2017 to 2022, and just like other studies, they had the typical cohorts that were developing their algorithm. So they had the development cohort where of 2,300 patients where they trained their algorithm. Then they had the internal validation cohort, which was from the same group of patients to internally validated, and then they had a separate group of patients, 698 for the external validation cohort to make sure that it was generalizable. And what they did with this sepsis immunoscore is they placed it in one of 4 distinct categories based on their risk of sepsis. So they had a low, a medium, a high, and a very high. And we'll get back to that in 1 minute. First, to kind of open the black box, as they've done in some other studies, they did a Shapley analysis, which is a Shapley additive explanation, or SHAP analysis, Shapley additive explanations values, which takes those 22 different parameters, as you can see in this table, and shows them as for the amount of weight that they were contributing to the score. And just curiously, procalcitonin, respiratory rate, and systolic blood pressure were the parameters that were contributing the most to the score that was derived. So in the results, these are the results for all of the 3 cohorts. The area under the receiver operating curve, the common measurement for most of these machine learning studies, is presented here for the derivation cohort. As you can see, had a AUC of 0.85, internal validation cohort 0.80, and external validation cohort of 0.81. So very high and acceptable scores across all 3 cohorts. Now, specifically looking at the external validation cohort, first I'll direct your attention down to the bottom table, and again, they were classifying each of these into based on their sepsis immunoscore, whether or not they were low risk for sepsis, medium, high, or very high. So first, looking at the low risk, you can see on the first little column that says patients, that's how many patients that they were looking, or that they had in the sepsis immunoscore that predicted that it was low risk. And then to the right of that, it has the patients that actually developed sepsis. So for the low risk, they had 232 patients that they deemed were low risk. Patients who actually developed sepsis from that group was 7, and so the sepsis predictive value was 3% for that. Then looking at the bottom, the very high risk, the number of patients that they had that they deemed a very high risk for sepsis was 33. The number of patients that actually developed sepsis out of that group was 23, a predictive value of 69%. And then up on the right here is a diagram of the likelihood ratios for each of these groups. So as you can see, for the low, and then going all the way up to the very high, and what they found, you can see the confidence intervals that are presented there, and they saw that the likelihood ratios is monotonically increasing, and the confidence intervals do not overlap, just again validating that this sepsis immunoscore does create like a distinct stepwise increased discrimination for sepsis. So conclusions, the sepsis immunoscore demonstrated a high accuracy for the identification and prediction of sepsis, and how they see this being used is that it, of course, like many other studies or tools, complements, not replaces clinical judgment and decision making. So say you have a patient who comes in with a heart rate of 105, a low-grade fever of 37.9, and is like borderline hypotensive, but doesn't have an etiology of an overt infection, and then you're wondering whether or not to start antibiotics because you don't have a source at the moment, and the vital signs are kind of equivocal, but their sepsis immunoscore says very high. It might push you maybe to start antibiotics earlier, maybe to escalate care if the patient was going to go on the general medical floor, or might update it to the PCU, or at least do telemetry, stuff like that. So that's how they see this being utilized at this point. Next study, in a little bit of the same vein, just in being that looking at early warning scores or trying to predict whether or not a patient will have clinical deterioration. So there are many early warning scores that were developed over the last years. Some of these AI, others non-AI. The non-AIs are very easily calculable, like with only on the back of your hand or whatever, just calculate it because it's just based on respiratory rate, blood pressure, and other things like that. The AI are right here. These are the ones that they looked at. There's they used the epic deterioration index which is not FDA approved, but it's widely available because it's integrated into the Epic EMR. The Rothman Index is one that was developed a few years ago, which is FDA approved. And then the eCard V5 was one that was developed over at the University of Chicago. And we'll get to that in 1 minute. And then the 3 publicly available simple aggregated weighted scores. These again are the ones that can be calculated by anyone just based on common vital signs, nothing too fancy, but are utilized by some hospitals just to try to warn of potential deterioration of patients. And so they compared all of these. They just found that there was no comparison of these prior to this study. So the main outcomes that they looked at, they were looking at clinical deterioration, and the way that they defined clinical deterioration was transfer from the ward to the intensive care unit or death within 24 hours of an observation. They had 362,000 patient observations, and they found that 4.6% or 16,693 experienced a clinical deterioration event, again, transfer from the ward to the intensive care unit or death within 24 hours of an observation. So what did they find? Again, using the area under the receiver operating curve, or AUC, they found that the eCard V5, again, the one that was developed over here at the University of Chicago, had the highest AUC of 0.895. And then surprisingly, as you see, the next 3 highest AUCs are actually the simple weighted non-AI scores, the NEWS2, the NEWS, and the MUSE. And at the bottom is the FDA-approved Rothman Index and the non-FDA-approved but widely available Epic Deterioration Index. On the right, they also calculated the median lead time, because if you have a score, say you get a high score for a patient that's going to deteriorate, but if that score coincides right when they're deteriorating, it's of no use because you're not able to give early antibiotics, you're not able to intervene in any way or escalate care. So they looked at the amount of time between the score calculation and when the actual deterioration event occurred, and they found that eCard V5 actually had the longest median lead time of 11 hours. And then again, the non-AI scores had the next 3 longest median lead times. And again, the Epic Deterioration Index and the Rothman Index were the worst. So, a very supportive study of eCard V5. Outperformed the other AI and non-AI scores, identified more deteriorating patients, fewer false alarms, and sufficient time to intervene. And then, surprisingly, the finding of this, one of the other big findings of this study was just that the non-AI, publicly available early warning scores, NEWS, MUSE, NEWS2, significantly outperformed the EDI. They specifically looked at the EDI just because it's so widely available in the Epic EMR, and this just shows that just because something's widely available doesn't mean that it works. So.
All right, and then building off of that prior study, the authors wanted to then obtain FDA approval, and so their goal was to obtain more data. So they were comparing in this study not to the Epic Deterioration Index or Rothman Index. They scoffed at those based on the prior results, but we're comparing to the NEWS, MUSE, and a prior version of eCard, the eCard V2. I don't remember seeing an explanation as to why they didn't use the NEWS2, which performed better than the others in the prior study, but that's what they chose. So they expanded the number of patients that they were including, and so then their derivation cohort became 900,000 patients, and then the validation cohort was almost 1.8 million patients, and then they had a prospective branch where there was over 200,000 patients. And of note, these were in 3 different hospital systems within 4 different states in the U.S. And so here for the data, so the labels 1, 2, and 3 are just within the different hospital systems. And so for the retrospective validation cohort of 1.8 million patients, the eCard V5 had an AUROC of 0.834, and again, with such a high number of patients, they're going to have very tight confidence intervals. And that well outperformed the clinical models, the MUSE and NEWS, and then as well as the earlier version, the eCard V2. But then I think notably in the prospective branch as well, there's a very similar performance to the eCard V5. And again, in the prospective, which we need to make sure that prospectively these studies are actually making an impact, the performance was well outperforming the comparators. So this study served as the foundation for the FDA's approval of ECAR V5. And then what I think was particularly notable is how the prospective data was similar to the retrospective data. So there wasn't too much of an issue of like overfitting or generalizability of the results.
And now looking at a different portion of critical care, this study was published in May of 2025, so just a few months ago, in Nature Partners journals. And the question that the authors were looking at was, can AI optimize post-op glucose control in the ICU, specifically for cardiac patients in this instance? And so just a little background on why this is important. So post-operative hyperglycemia after cardiac surgery is common, occurring in about 60 to 80% of patients with diabetes and 50% of non-diabetics. And other studies have found that only 15% of patients had appropriate glucose control, 70 to 180, within the first day after cardiac surgery. And other further studies have shown that poor glucose control is associated with higher rates of post-op infection, acute kidney injury, cardiac arrhythmias, longer length of stay, and higher mortality. So obviously these are very sick patients, and this, though may not be as important of an issue just in a generalized hospitalized patient, but in these cardiac surgery patients, very important just given the high or the great insult that getting surgery, has on the body. So the authors named their algorithm glucose, which stands for glucose level understanding and control optimized for safety and efficacy. And they sought to optimize insulin dosing specifically for patients recovering from cardiac surgery. So obviously by optimizing these dosing decisions, the algorithm sought to reduce complications associated with the imbalances and improve postoperative recovery. So just like most other machine learning studies, they had 3 different cohorts. They had the training data set of about 5,000 patients, the internal validation cohort, which had about 920 patients from the same hospital system. And then to make sure it was generalizable, they had the external validation cohort of 649 patients from a different clinical setting. And what they looked at for a measure of how accurate or efficacious their algorithm is they looked at something called mean absolute error, and they compared the mean absolute error with the algorithm to expert clinicians in predicting the amount of insulin required to properly control a post-op cardiac surgery patient's glucose. So, and they found, or other studies have shown, that lower MAE correlates with better safety and efficacy, reducing hypo and hyperglycemic risks. So for the internal validation cohort, the glucose machine learning model had a lower MAE of 0.9 units than clinicians of 1.97 units, showing better dosing accuracy. And that was significant to a p-value of 0.001. And on the right, you can just see a simple diagram of the compared MAEs for the clinicians in gray and then the glucose algorithm in yellow. And so for the external validation cohort, again, the glucose machine learning model maintained a superior accuracy of 1.9 units of mean absolute error compared to the clinicians' 2.24 units, again, statistically significant to a p-value of 0.003. So conclusion, the glucose algorithm outperforms traditional clinician dosing strategies, reducing dosing errors significantly, and hopefully reducing the complications and having better clinical outcomes. So the authors feel that the best use of this algorithm would be to come up with standardized data-driven postoperative care protocols that would minimize complications and reduce the glucose variability. Obviously, that'll be a big ask, or to incorporate that in the day-by-day post-op care, but that's kind of the goal. And then the next study, kind of moving back to clinical deterioration, which is a big theme in those machine learning studies that are kind of involved in the hospital, ICU care. These authors published a study in May of 2025 in Critical Care Explorations, and they were asking, can AI predict deterioration in community-acquired pneumonia patients? So specifically, they wanted to develop a machine learning model to predict the need for 3 different factors that are indicating clinical deterioration. The things that they looked at was the need for invasive ventilation, vasopressors, and renal replacement therapy. And they specifically looked at just hospitalized community-acquired pneumonia patients. And they trained different ML models. These ones listed here: random forest, support vector machines, extreme gradient boosting, and multi-layer perceptron. And then they compared these machine learning models to a simple traditional model, logistic regression, to determine the prediction accuracy. And so they looked at both COVID and non-COVID patients. They had a total of 4,329 hospitalized adult CAP patients. More than half of those were COVID, and then a little less than half were non-COVID adult patients that were hospitalized. And again, they looked at only community-acquired pneumonia patients that did not require any of these invasive interventions upon admission, and then whether or not they would when during their hospitalization, and how well that the machine learning model could predict that. So this is a little bit of a busy slide. This is showing the model performance and metrics, and this is for the external validation cohort. And at the top, you can see color-coded. Hopefully it shows up decently there. On the top, the little color codes at the top is the light brown is for the need for renal replacement therapy. The little bit darker brown is the need for vasopressors, and then the darkest brown is the ventilation, or the need for ventilation. And these are the AUCs for each of these. And on the left, you can see kind of the stepwise decrease in the AUC numbers, and the left is the random forest classifier, and then all the way to the right is the logistic regression. So for the random forest classifier, you can see that for predicting renal replacement therapy, it had an AUC of 0.85. Then for predicting the need for vasopressors, it had an AUC of 0.9. And then for predicting the need for invasive ventilation, an excellent AUC of 0.95. And then the other 3 machine learning models that they looked at were just kind of showing at least similar or equivocal AUCs to the logistic regression, if not better, for all the different measures. So just again, showing that random forest classifier was the best at predicting this, and it could predict these invasive interventions for these CAP patients. So as I just said, machine learning models showed superior accuracy than logistic regression with AUCs up to 0.95, indicating a strong prediction for the need for critical interventions. Again, intubation, vasopressors, RRT in CAP patients. Random forest classifiers were the best performing ML models. And just like all the other studies, they believe that the best utilization of something like this would be to augment clinical judgment rather than replace, just enabling earlier intervention with patients that were predicted to have potential deterioration. Again, allowing for escalation of care or small or big changes in management earlier to prevent this deterioration.
All right, and then for the next study, the authors were saying, mortality in mechanically ventilated patients is an important goal that we want to improve on, we're constantly developing new AI algorithms, ways of potentially improving our performance. They knew of other studies in this field, but we're hoping to use kind of newer approaches to improve their results, as well as they had the critique of other studies not being particularly externally generalizable, not really taking any safeguards to try and improve external validity. So they wanted to perform a study and use a model that improved upon those. So first they had to get data, and so they used the MIMIC-3 data set out of Beth Israel Medical Center. They searched by ICD-9 codes to find mechanically ventilated patients, sorted by or excluded patients outside the age range of 18 to 90 years old. Of course, required complete mortality information for a study on mortality, and then did statistical methods to deal with missing data, those sorts of things in large data sets. So ended up with 25,000 patients, selected features to include in their model by backward elimination and the lasso method. And then, so they compared against a number of existing AI machine learning models, but at the bottom left, the CAP boost model was one that they were proposing would outperform the prior models. So XG boost had previously performed the best, but they felt that this CAP boost model was going to hopefully outperform and then also have better external validity. And so in looking at, they measured a number of different outcomes, but looking at the AU-ROC just for consistency with this talk, the CAP boost did outperform all the other AI models. And as I believe Dr. Osborne said yesterday, all of these technologies are the dumbest that they'll ever be. And so moving forward with that, the newer the model, the better that we're able to apply it, the better the performance. And so again, the newest model outperformed all the prior versions. And so they wanted to use CAP boost because it's known for its superior handling of categorical variables as well as computational efficiency. And while the prior best AUC was 0.821 using the XG boost, which they compared to, the CAP boost didn't have nearly as great of a performance over XG boost in their study. However, it did require far less clinical variables, reducing the computational requirements. So whereas previously there were 55 predictor variables, now there are only trying to figure out how to get rid of feedback. CAP boost to get their results, they only required 32 clinical variables. And then again, for addressing external validity or generalizability, they used this SMOTE approach to try and reduce kind of overfitting of the data so that it would better perform for minority populations. And then another study out of South Korea, Seoul University Hospital in South Korea, the authors wanted to develop an AI model that would predict ICU readmission rates. Predict ICU readmission rates and hopefully use this information to try and determine when a patient's actually ready for downgrade from the ICU. Because let's say clinically the ICU team thinks a patient is ready for discharge, but this AI model says, hold on, wait a second, for some reason, their ICU readmission risk is relatively high. Maybe that would take or give the team an opportunity to pause and really closely reevaluate everything that's going on with the patient and maybe detect something that they might have otherwise missed. So they took a continuous number of patients admitted to their ICUs at, again, Seoul National University Hospital, South Korea, which ended up being 70,000 patients. But then they also wanted to try and test external validity. And so they used the MIMIC-3 data set, of which they had 43,000 patients, as well as the EICU data set, of which there are over 90,000 patients. And so then took all the clinical variables of just everyone discharged from the ICU, and they segregated into two groups. Either you were normal, meaning after discharge from the ICU, you were successfully discharged from the hospital, or you had a deterioration on the floor requiring ICU readmission, the patient expired on the floor, or the patient was made DNR and presumably was in a state where they were going to end up getting readmitted to the ICU anyway. And so then they developed their model, and at the bottom, I think is a good representation of the goal being this iRead score, which is meant to be ICU readmission risk. If you're getting ready to discharge someone from the ICU or downgrade someone from the ICU, looking or using this model to compare to what clinical decisions prior clinical decision making would suggest, and if at the time of ICU discharge the patient's iRead score is above a certain threshold, maybe we second guess whether or not they're truly ready and reevaluate things a little bit closer to try and prevent that ICU readmission. So they were looking at both early, which they were saying was within 48 hours of ICU discharge, readmission to the ICU, and then late readmission to the ICU, so someone who returns after 48 hours. And they were comparing both to a number of clinical models that we've discussed earlier, as well as some other machine learning models down at the bottom. Their iRead model outperformed all of both clinical models as well as machine learning models. What I would note is that, so this AUROC has some room for improvement, but also there's a bit of a step down when comparing to the other data sets. And so while it was probably or might be very helpful in the cohort that they have at their hospital, I think there are some gains to be made in terms of U.S. populations. And then for late readmission, the model performed better, which surprises me a little because I would think that the clinical variables at the time of ICU discharge would better indicate if someone is going to need a ICU readmission within 48 hours versus someone needing a readmission in 7 days. Now maybe the model performed better because someone with chronic conditions that lead them to have high rates of ICU admission are more likely to deteriorate on the floor. But it was a little curious that the late readmission actually performed better. But still in this cohort, there was better performance in their own derivation cohort than in the external validation cohorts. So this iRead model did outperform clinical models as well as other machine learning models, and uses only a limited number of clinical variables to predict ICU readmission. But I do think there needs to be some improvements both in terms of performance as well as external or generalizability for it to be in widespread use. But it's a very intriguing direction.
All right, and then the ninth study that we were looking at is a study that was just published a couple of months ago in Scientific Reports, July 2025, and these authors were asking, can AI predict next day extubation? So, as any critical care physician would know, about 20% of patients who you extubate are going to be reintubated, and so obviously this is a big issue, and the current measures that are used, to try to predict whether or not a patient is extubatable are largely SBT or various clinical protocols that are in place in the ICU. And so these authors just wanted to see if a machine learning model could predict this. So the way that they developed their model, they looked at patients from 2018 to the middle of 2023, and they split up the patients from 2018 to the middle of 2021. They had their development cohort. That's their training. They used 80% of those for their training data set, and then the last 20% for the internal validation, and then everything from the middle of 2021 on was the external validation or test set. And they reviewed all of the electronic health records for all these patients, and they compiled 37 features just from 12 a.m. to 8 a.m. of the prior day. So they didn't look at stuff from all the admission prior. They just looked at the 8 hours prior to usually when a patient would be extubated, which would be on morning rounds the next day. They just wanted to see if that the parameter measures that were measured during that time could predict the next day extubation. The stuff that they looked at, for example, mental status, support devices, vital signs, labs, ventilation parameters such as plateau pressure, peak pressure, etc. And they developed their model by labeling the next day's extubation status. So from day 1, if the patient was extubated on day 2, then that patient was considered extubated. If they were still intubated, then they were marked as intubated. And they saw how these parameters could predict whether or not the patient would be extubated or not. They trained and evaluated their models, and then they tested it on the external cohort. The models that they looked at, they used 2 traditional models, XGBoost and Light-GBM, along with a more traditional model, logistic regression, and they compared that to 2 deep learning models, long short-term memory and random neural networks. The study population that they used for the internal cohort, they had 448 patients with around 3,000 ICU days, and the external cohort had 333 patients at another facility with around 2,800 ICU days. And again, they used 37 different clinical features aggregated daily just from 12 a.m. to 8 a.m. the previous day to predict the next day extubation readiness. So then looking at, again, the AUROC, this is just looking at, hey, Dad, can you mute your? So they were looking at the receiver arm of the operating curve characteristic, and on the right, specifically for the deep learning model, the long short-term memory was the best model that predicted next day extubation. So that had an AUC of 0.87 for the internal test cohort, and then had a AUC again of 0.87 for the external test cohort. And on the right, you can just see is the plot of the first. All of the different models are plotted on the top right, and then just separating the LSTM model on the bottom. And again, they did a kind of opening the black box, seeing which of these 37 parameters contributed the most, and they found that, interestingly, the RAS score, then the bicarbonate level, and then the GCS motor response were the biggest predictors of whether or not the patient was ready for next day extubation. So, what does this mean, or what are the clinical implications? So the model did predict, so the model they found predicted patients as extubation ready several days before the actual extubation. And the reasons that they came up for this is just that when a patient's evaluation, like an SBT, other clinical parameters that they're looking at are kind of equivocal, physicians, they purported, tend to leave a patient extubated rather than risk extubation and then reintubation. But this model was predicting, the LSTM model was predicting that the patient consistently was ready for extubation several days before, and they found that 63.8% of predicted extubations occurred within 3 days of the true extubation. So, validating the model that it was relevant to when the patient was actually extubated. So what they see this, again, as pretty much all the other studies that I looked at, they see it as a clinical support tool at this point. Not replacing clinical judgment, but in addition to the SBTs, other clinical protocols that are in place in ICUs, it would help clinicians make the decision whether to extubate or keep a patient intubated. Say that an SBT is equivocal or other clinical parameters are not pushing one way or the other. If they ran the model on the clinical parameters from the previous day, it says that the patient's ready for extubation, maybe that would push for extubation earlier.
And then our final study. So the goal of this one is to hopefully kind of develop technology that allows us to use just regular RGB video to help support our ICU tasks, particularly kind of like ICU bundles. And so working on improving the technology by using computer vision in order to kind of validate that all the elements of ICU bundles are being performed. And so this requires taking a whole bunch of test data, training data and labeling all of the different frames with objects and relationships between those objects. So as you can kind of see from the middle here, this kind of relationship diagram between objects and relationships. And so this was all trained into the model by labels that were manually applied to each frame, with the hopes of this kind of improving on or outperforming prior algorithms or models that are attempting to do the same thing, with the goal of eventually having this sort of technology help support and improve, the compliance with like SCD being placed on patients, or that the head of the bed is up, that we're doing regular suctioning, those sorts of things. So now they did a number of cross-validation measures, and they used a performance metric of mean average performance, which I still don't particularly understand. They didn't go into much detail about it, and I don't have much experience with it. But there was significant performance gains over the prior best models that they were referencing. And what I think, the sensitivity was not particularly high, so there's room for improvement in this field. But I do think that this is kind of, if it can be used well, this sort of technology would be very helpful in helping make sure and support all of our multidisciplinary team in ICU, in making sure that we're being consistent with the measures that we know improve patient outcomes, and helping to provide us real-time feedback on things that we might have missed as a human, but the computer is able to be a real-time and relatively cheap double check, so that we can improve those outcomes.
All right, so just in summary, we went over 10 studies, the first 5 that we went over, and as you can see consistently throughout all of these, a lot of these, nothing is revolutionizing care in the ICU. None of these are going to show up and just change management, but all of them are complementing clinical decision making already. So first paper that Patrick presented on showed that ML models, ML continuous ECG models can help identify clinical deterioration. The one that I presented just shows the sepsis immunoscore, classifying patients into low, medium, high, and very high risk, can identify patients who are at great risk of sepsis. Then the ECART V5 model that was developed over at the University of Chicago outperformed other all other AI early warning scores, specifically the Rothman Index, the Epic Deterioration Index. So that is shown to be the highest performing early warning score, and actually the Epic Deterioration Index performed worse than the typical aggregated non-AI scores, NEWS, NEWS2, and MUSE. And the next study that Patrick presented was the ECART V5 getting its FDA approval. Then I presented the glucose ML model, which demonstrated that it had a lower mean absolute error, optimizing post-op cardiac surgery glucose control. Then the ML models can predict invasive interventions in CAP patients. ML models can predict mortality in mechanically ventilated patients. ML models, specifically iRead, can predict ICU readmission, risk and discharge readiness. ML models can predict extubation readiness, and the Clinical Behavioral Atlas with computer vision can optimize ICU care. So, thank you all for your attention, and we welcome any questions.
Hey, great talk, JC, from Rush, and also a care doctor who's done some of this work in the past. I can sort of talk a little bit about the readmission question you had. In 2020, I fit a model very similar to the paper written by the Solver, and found the same pattern actually with Renforce and machine-use model that machine learning typically picks more chronic illness as opposed to like the physiological vital signs we believe. So labs like your BUN or even RW, these things are sort of picked up by ML3-based classifiers is important, and then ultimately I think those people that are going to get readmitted at some point, if you're just sort of, for lack of a better word, chronically unacceptably ill,
Right.
I will come back to the ICU at some point, but maybe not the next 24 or 40 hours. And interestingly, I have sort of given up on the ICU readmission space, but it's sort of reinvigorating the book. But the performance is sort of similar to what I've done. So I think there's room for improvement, but part of it is that people get readmitted to the ICU for so many different reasons. It's not just physiologic, it's nursing, it's sometimes family,
Sure.
a variety of things. Whereas, the flip side for early warning scores, I think this is sort of a clear impetus that I think if you're not using something, even if it is news, you should be using something. I think
Yeah.
hospitals in the United States aren't using any rule-based algorithms to sort of think about escalation of care, and it's just sort of vibes. Probably are not as good at any of the things you present.
Right.
That's step one is getting people to use the
Yeah.
Floating the competency questions, thanks.
But yeah, use the poor performing model rather than no model. All right. I don't know if, yeah.
Thanks so much.
Thank you.
Thank you.
Hey everybody, John here. Thanks for listening to another episode. If you enjoyed what you heard here today, please check out our website at www.americancollegeaim.org. Sign up to become a member. Also, save the dates, October 9th and October 10th, 2026. We'll be back live in Chicago, Illinois at the McCormick Place Convention Center for our second annual live scientific session. Sign up at the website to attend. Until then, we'll see you all on the next Melvin Monday. Thanks for stopping by. See ya.